Welcome to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this Health Literacy Out Loud podcast that focuses on many aspects of health communication, patient education, and health literacy. Today's guest is Dr. Samantha Sobie, who is a neonatal nurse practitioner and clinical specialist at AngelEye Health. She has over a decade of experience working in NICU, or Neonatal Intensive Care Units. Samantha's doctoral work focused on assessing health literacy and improving the NICU discharge process. She now combines her clinical expertise with digital innovation to support families and care teams during the NICU journey. Samantha, welcome to Health Literacy Out Loud.
Hello, Helen. How are you today?
Just took a drink because I have a scratchy throat. So as you and I both know, health literacy matters throughout the age span. And I have focused on a whole range of that, but never about newborn care. I'm really excited to do this. Can you just explain to all of us a little bit more about neonatal care?
Yes, I would love to. So the NICU, the Neonatal Intensive Care Unit, is a very special place that not many people know about. So the saying is typically, you don't know about us until you actually have to go to the NICU or know somebody that was in the NICU. So we handle all sorts of infants, so we have premature infants, full-term infants, and there's a multitude of reasons that a baby would be admitted to the NICU.
Tell us just a few. You know them, but we've got listeners from all over the world, may or may not be in clinical practice. Just give an example about why would a brand new baby be in a NICU?
Yeah, so sometimes infants can be admitted to the NICU if they don't transition well into extrauterine life. So, if that baby comes out and doesn't want to breathe as effectively and transition to extrauterine life as well as they should, sometimes those babies can come to us and get a little bit of oxygen. And then, we really span the gamut. So we have infants and newborns that can have congenital heart defects. They can have various syndromes. They can have genetic anomalies, all of those various things. So we really see the gamut when infants are admitted to the NICU.
Okay, when I think of the term ICU, which is part of neonatal intensive care units, it is kind of a crisis. Are you seeing babies and their parents in crisis?
I feel like that's a really strong word, but also a very necessary word. So in the NICU, you have to think about it this way. So a mother comes in, she may or may not be aware that she is going to deliver that day. So if she has a premature infant, she's likely unaware. If you have a full-term infant, you think everything is going to go great and that you're going to go home with that baby, but something happens and then you're separated from your baby. And it's almost immediately, depending on the severity of how that infant is presenting. So these parents are separated from their baby. Their baby is taken to a different unit where they are admitted. And you're exactly correct, Helen. When we say ICU, we have infants that are on ventilators. They are on multiple different IV medication drips. There is a multitude of tubes, wires hooked up to these babies because they are in very intensive care. So, in the normal adult world, you're not typically hooked up to a monitor, but in the NICU, every single baby until they go home is hooked up to a monitor because we want to watch that baby's vitals from the second that they enter the unit until the second that they leave. So it is very intimidating for these families and actually can cause quite a bit of trauma.
And that's what I'm curious about. Obviously, we're talking about health literacy. We're talking about communication. For the baby, thank you for doing all you're doing for the health of that child, that newborn. But what's it like for the parents? And how does health literacy play into this?
Yeah, like I mentioned, this is an incredibly traumatic situation for, I would say, every single family. Whether their baby's there one day or 6 months, they are going to be experiencing a traumatic event in their life. So in the NICU, we try to focus on providing trauma-informed care.
What does that mean?
So trauma-informed care is when we acknowledge that the birth process, an infant being premature, an infant being admitted to the NICU is a traumatic event. And we try to address that baby and that family in a very trauma-informed view. So instead of, saying something like, "What's wrong?" you say, "What happened? Like, what happened to you?" You kind of change your lens and put yourself in their position where we're trying to provide, protective measures at the same time. So we have different practices that we'll do. We try to reduce light and noise and stimulation. So that's why NICUs are always very quiet. So we try to utilize this trauma-informed care and practice to help our families feel a little bit safer in the NICU and feel like they can really be the parents that they want to be.
So you are caring for more than one person. You are not just caring for the baby, you're caring for the parents, or I don't know if there's ever more than one parent who is allowed in, so I don't know what that's like. Is there just one parent allowed at a time, or do you have 2 parents? Do you ever have the whole family?
Yeah, that's an awesome question. So, any normal NICU assignment can be, 2 to 3, sometimes 4. I've even seen 5 infants per nurse. And then when you tack on the addition of 2 parents to that,
Oh,
that
okay.
gets quite busy. So, the more intensive that baby is, the more education that you need to provide to that family. And likely you're going to be spending more time with that family as well. So, a 2 baby assignment is typically a very intensive assignment, and then you have 2 parents on that, and now you're looking at 6 people and trying to read, the emotions and be sensitive to 6 people in total. So it can get very busy very fast.
All while you're providing the essential medical care. So tell me about this. You're well versed in health literacy. How does health literacy become part of this process?
So I originally fell in love with health literacy when I realized working in the NICU, the discharge packets that we handed out were just gigantic paragraphs on a white sheet of paper. And as a nurse, I was like, oh, I would not want to read this. This is not fun and engaging. So that's why I set out to make that my doctoral work. And it really just shows how whether you are in the adult world or in the NICU world, health literacy and education materials are more important than ever. So, like I mentioned, these families are coming into a unit and a world that they have never experienced before, unless you're a return, NICU parent. And that is incredibly overwhelming. And then, not to mention, we're starting to talk about diagnoses and treatments and care plans and things like that are not commonly heard. A lot of people have heard of jaundice, but some people may not know about kernicterus, which is when jaundice gets super high and that baby can have seizures.
Okay.
You kind of come in with a little baseline knowledge, but there is a huge amount of knowledge that you need to learn when you come to the NICU, and that is incredibly overwhelming and really why health literacy is so important for these families.
Tell us a story. You know this. This is your chosen work. I'm thrilled that you're doing what you're doing. Tell us a story of how you would explain something scary and new or whatever that the parents need to know, and it might be complicated medically. How can you explain it at that moment in ways people can truly understand and use?
Yeah, I always think of this example of this baby that I had, and she had muscular dystrophy, and we were getting her ready to go home. So typically, babies that have really intensive diagnoses and have really extensive discharge teaching, units will try their best to provide a primary nurse. So I was this baby's primary nurse. And we had to do a lot of teaching before they went home. So they were going home with suction, they were going home with oxygen. This baby had a G tube, which is a gastric tube, which helps with, tube feedings when they go home because feeding by mouth is unsafe and may compromise their airway. So there was a lot of teaching that this family needed to do, and these parents were very, very young. So what I did was I sat down with them and I said, "Hey, let's talk about what you know and what you feel like you don't know."
Oh, a wonderful place to start. You're not
Yes.
just assuming they know nothing, and you're not assuming they know a whole bunch.
Yes, because we want to take those portions that if they say, "Hey, I feel really confident in using the suction to suction my baby's mouth," then I want to make sure that I focus on that. And I want to make sure that I put a lot of kudos onto that when they do it. So because you want to instill that confidence as well, because whether you are a a first time parent, a third time parent, I feel like the birth process and going home from, the hospital is always overwhelming and always new. So, you want to really focus on those parts that that those families really succeed in, and then fully support those aspects that they don't. So what we did was this baby had a lot of medications that she had to take when she went home. She had medications around the clock. So every 3 hours, she had a different medication that she needed. So what I did was I printed out a hour by hour, like 24-hour spreadsheet and what medications would go where. And I walked through the parents. We had the boxes of medications in front of us. We practiced drawing everything up and we went hour by hour on, okay, what is she going to get this at this time? What is she going to get at this time, until they felt completely confident that they could do this at home on their own.
Samantha, I'm so impressed by this. You are really, I'm thinking of all the health literacy principles that you and I both know, starting with what do they already know? What do they want to know? You're giving acknowledgement for what they're doing well. Then you're breaking the hard, unfamiliar parts down to a simpler component. And it sounds like you're also doing the teaching kind of hands-on. You're observing the medical procedures that the family will be need to do or allocating the medications. It's just really health literacy in action. Wow. Um, so we don't always have Samanthas in our lives, especially when things are at a crisis there. What are listeners for Health Literacy Out Loud? They may be clinicians like you. They may be in public health. They may be at community organizations. Listeners can be from anywhere. But what we have in common is we all want to communicate better today than we did yesterday. What are some tips and strategies that you would like to share?
I feel like there is a framework that many clinicians are very familiar with, and that's the 5 rights of medication administration. So, the right patient, right dose, right route, right time, all of that great stuff. And if we can take five rights that 5 rights framework and really provide it to our families and put it in the framework of education. So, we want to make sure that when we are talking to our families, that we are ensuring that not only is it the right patient, but maybe in the NICU or in a pediatric unit, is it the right caregiver? So are we talking to the right person? We also want to make sure that it's the right time for this family to hear it, because if you come and try to educate this family in a really stressful time, they may just forget everything. Everything might go out the window if you just gave them
Of
some bad
course.
news.
So it's not your right time of when you have to do it before your shift ends. It's the right time for them to hear it. Okay.
Exactly. And then you also want to make sure that it is the right education. So, am I actually providing them the exact education that they need? So, if I'm going to go in there and talk about jaundice, do I have the jaundice education with me? Am I making sure to stay on task and, not deviate into other areas? Like, I want to keep them focused on one topic. Am I utilizing the right route of education? So, personally, I am a visual learner. So if you bring me something with pictures, maybe a video, I am going to absorb that way better than I would just a standard handout. So, You want to make sure you have that right route as well, and then the right dosage. So we don't want to come in and overload our families with a ton of education at once.
So it's not just medication dosage, it's dosage of education. Okay.
Exactly. So we want to make sure that we're also providing the right amount. So you don't want to come in and give them 30 minutes of intensive, education and new information. Maybe you need to break it up a little bit. Maybe feed the baby a little bit and then come back to that education and talk about it a little bit more. So really utilizing that framework emphasizes how powerful education truly is. So misinformation, miseducation can be just as detrimental as the wrong medication to a patient. So we want to make sure we are truly and fully preparing these families before they go home. And I feel like that 5 rights framework is a pretty great way for clinicians to assess how they are going to educate that family.
It is. What a comfortable framework it sounds like. On your Health Literacy Out Loud webpage, let's have a link so people can learn more about that. Are there any parts of it that are extra hard? You learned this in nursing school. You've been a nurse for quite a while. The rest of us may not be, or for whatever we're doing in our chosen careers or our lives. Are there things we have to watch out for? Is it as simple and straightforward as you're expressing it?
At a high level, it is for sure. But you know just as well as I do, Helen, that whatever you're teaching and whatever you're educating, there's always nuances. And depending on that patient and caregiver, there's even more nuances as well. So it can get very complex. So definitely, I feel like that 5 rights framework gives you a really good overview and kind of an initial first steps on, how best to go about it. But obviously, there's always complex needs and, reasons that 5 rights framework might not apply and things like that. But it's a good place for us to start as caregivers.
I'm trying to be thinking about, for a public health way, how would you do your teaching in consideration of this? Maybe you're doing teaching, but you don't have just one person in front of you. Or it might be a public health, a broader message, or a librarian, perhaps, where you might have one patron in front of you or with you, but you don't know that person very well. Are there components of this you do think that will hold up in those varied situations?
I think it will. I think it will. And I think that you can kind of reshape it for whatever environment you're in. And I love your example of the librarian, if a librarian's trying to help someone find a piece of education, to help them, they can just kind of rework that a little bit. Maybe the right time might not necessarily apply to them because clearly that person has come into the library and they're looking to learn now. So maybe that's not necessarily applicable.
So it is the right time already, and it is the right person, perhaps, but it may or may not be the right person. Let's take this a little further, if I can indulge that. Let's say someone comes to the library and tells the reference librarian, I was just recently diagnosed with diabetes. I want to find information. Help me. How would you break down this framework in that situation?
So I think it's good to start at the top. So, right patient, right caregiver. So are we talking to the right person right now? I always feel like a conversation to get education started is super beneficial. So I feel like that librarian could essentially start a conversation with this person and say, okay, that sounds good. Let me help you today. And then they could also ask, is there anybody else that you feel would benefit from this education? Maybe a spouse, maybe a brother or sister that's going to help you through this journey with this new diagnosis, making sure that you have the right caregivers, right patients involved in that education. And then, like you said, it's most likely the right time because they came in, they walked in, they're ready to learn. And then in terms of right dose, right route, all that other great stuff, I feel like that also comes out of that conversation as well, where that librarian in that conversation, she can say, hey, well, how do you learn best? Do you like videos? Do you like books? What do you like? What kind of sits well with you? And she can tailor that education search down a little bit more for them and make it really personalized.
Thank you. I'm also thinking of maybe that person has a child that they're concerned about, or maybe they're coming on behalf of somebody else with the situation. You can also tailor that information and your recommendations. Samantha, this is wonderful, really health literacy in action. I see a big smile on your face. You can hear it in your voice for the people who don't have the pleasure of looking at you. Are there any messages or words of wisdom you want to pass on to our listeners?
I think just words of wisdom is I always feel like putting yourself in the patient's shoes can be really beneficial. And I know it's kind of cliche to say,
Okay.
but I always imagine when I go to educate somebody that I'm talking to my brother or I'm talking to my mom. And I want to come into that conversation with just as much empathy for this patient that I maybe don't really have a relationship with yet or may not know, because you never know when it may actually be. I feel like parents come into the NICU and they don't realize that today might be the worst day of their life up until this point, having their baby separated from them. So you want to walk in just being aware of that, hey, this person might have suffered some trauma getting to this point, and they're sitting in this chair, probably very emotionally shaken with what has happened. I need to show them a lot of empathy, and I need to be an active listener and read their cues and just really pay attention to what you're saying as well, because everything that comes out of our mouth as caregivers not only affects these parents, but can also affect that baby down the road as well.
Samantha, you're wonderful, providing lessons for us all about how to teach, when to teach, who to teach, how much to teach, and listening actively. Thank you so much for being a guest on Health Literacy Out Loud.
Thank you, Helen. It was such a joy to be here. I am so happy that I got the chance to talk to you today. You have been such an inspiration for all of my doctoral work. I'm a little bit of a fangirl right now.
I didn't expect that. Thank you. It takes all of us. Thank you so much, Samantha.
Thanks, Helen. Bye-bye.
As we just heard from Samantha Sobie, it's important and helpful to include health literacy all along the age continuum. But doing so is not always easy. For help clearly communicating your health message, please look at my book, Health Literacy from A to Z. Feel free to also explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud interviews come out the first of every month. You can get them all for free by subscribing at healthliteracyoutloud.com or wherever you get your podcasts. Please help spread the word about Health Literacy Out Loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.